Thank you. I'm Jennifer Wyman for those who don't know me. And we'll jump right in. I'd like to start with our land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. These are the ancestral homelands of the Huron-Wendat, the Anishinaabeg, the Mississaugas of the Credit, the Haudenosaunee, and the Attawenderons, or Neutrals, and is home to the Dish with One Spoon Treaty. PHI recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. PHI respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. And I hope that we can all reflect on the territories we are calling in from as we commit ourselves to gaining knowledge, forming a new culturally safe relationship, and contributing to reconciliation. I'm so pleased to invite you to welcome you to today's conference. It's been a long time in the making. I wish that we could be gathering around the coffee tables and seeing each other in person. But we have a number of ways to interact, and I'll go over those in just a minute. I'd like to quickly just run through the outline of the day, some of the ways to use the platform, and some thank yous before we jump right into a very full first day of 2. So just to remind everybody, our keynote speaker, Carol Hopkins, will be a large session for everyone. And following that, we break out into parallel sessions. There are 2 parallel sessions with a workshop, both in the morning and in the afternoon. We have built breaks in this year, unlike last year. So hopefully everyone gets a little bit of a breather in between to make their transitions and answer their messages. And I hope that will allow us to chat with one another virtually and also not be so involved in multitasking that we miss the great content that's going on in the sessions. After lunch, we'll convene all together for our panel on OAT during COVID, what we've learned and where we should be heading. And then we move after that session into the poster presentations and chats, and I'll speak about those in just a moment, back to parallel sessions. And then at the very end of the day, for those who still have interest in our keeners, I know there are some of you out there, we'll break into the networking interest groups. And those groups are really informal. They're just a chance for people who share interests, whether practice locations or themes, to join and have some less formal conversations and maybe do some planning about work that they'd like to continue after the conference. So tomorrow follows the same format in terms of parallel sessions with workshops in the morning and the afternoon. And our featured presenter, Yvette Perot, with a session that is both content and some experience or memorial dealing with grief and loss in the overdose crisis. So in terms of, I'm missing a little bit of a slide, but that's okay. In terms of interacting, if you look at your conference platform, the most important button there is that little tech support button at the bottom left. So any questions that have to do with tech and using the platform at all, click on that. I know everyone is great at emailing Kate, Sarah, and Lori. They're not the tech people for this, so we'll use CPD for that. If you look at your regular login, I hope what you can see along the column on the left that I'm not seeing now are ways that you can interact. So there are little windows that tell us who the speakers are, but if you go to that networking button, you can see everyone who's attending the conference. So please make sure that you check out who's there. You can message people individually or privately. You can also create a little group chat if there are 2 or 3 people who share a theme. And we really encourage you to use that, as well as messaging and Twitter. If you click on the sessions, you'll see that when you go into the breakout sessions, it will say sort of breakout versus workshop. If you're not sure where you're supposed to be, you'll see that if you further click on breakout, you can choose session 1 or 2 if you're not already registered for a workshop. And you can actually move back and forth between those sessions. You just can't move into a workshop if you haven't already registered. And if by some chance you didn't register and you have a burning desire to get into a workshop, I think that's probably still okay. Again, please use your tech button. So without further ado, please enjoy the days, send lots of messages. We're really looking forward to feedback. Don't forget to fill out all of your conference evaluations for the sessions and for the day overall. Just a reminder that the accreditation letters will be sent out within a couple of weeks, and that all sessions except our workshops will be recorded. It will take us a while to get those edited and up for viewing, but everything that you've seen other than the workshops will be available for viewing later. Lastly, I'd like to thank the Scientific Planning Committee, who have come together to create what I believe is really an exceptional day with a range of content that expands beyond anything that we've done before, to include both clinical topics, research areas, RAM innovations, and a lot of more presentations than we've ever had before from people with lived expertise and families. And I would be remiss if I didn't thank the speakers who have put so much effort into creating these presentations, our moderators and facilitators, and of course in the background, Sarah and Lori. So thank you. Please enjoy the conference.
Just to very briefly say, I'm giving an environmental overview of where things stand in the opiate crisis. We are in the midst of the gravest substance-related public health crisis in modern history. Harms from alcohol and opiates are increasing. They've been increasing in the years preceding the pandemic, but they're getting worse now. This is just opiate-related morbidity and mortality. ED visits in January 2003 in the midst of the OxyContin crisis, 23 deaths. January 2016, at the start of the fentanyl crisis, 77 deaths. May 2020, 246 deaths. So things are 11 times worse for opiates than in the midst of the OxyContin crisis. It's unprecedented. Opiate-related harms have accelerated greatly in the pandemic. 50% increase in opiate deaths from 2019 to 2020. And it's not just opiates, it's also alcohol. We see a marked increase in ED visits for women and for men, more so proportionally for women. And the greatest increase in ED visits for alcohol-related causes was in young women. The one-year mortality rate for people who visit the ED multiple times in 1 year is 5.4%, which is about the same as the mortality rate, one-year mortality rate for injection fentanyl users. So people are dying from alcohol, in fact, probably at greater numbers than for opiates. The Mental Health Commission of Canada shows a marked increase in opiate deaths, in alcohol consumption. 8% in this national survey reported greatly increased consumption. COVID and substance use, of course, has made everything worse in so many ways: social isolation, depression, anxiety, the quarantines, loss of income. And at the same time, things are getting worse in terms of substances. People have been afraid and have been, in a way, warded off attending the ED and other healthcare settings for help. So you can see that the weekly ED visits for mental health among youth in the 7 days in February 2020 declined in the following year by 500 visits provincially. The drug cartels, I think when we're talking about the toxic drug supply, we have to understand that these are business decisions deliberately made by criminal gangs, so that the composition of the drugs has been modulated and titrated to become more and more potent. And this creates, so when they're selling fentanyl, they're meeting a demand that they themselves have created. They put potent fentanyl on the market, and then people get addicted to them. They want that, so they sell more and more potent products. Other drugs, it's the same. Crystal meth, while it's not as lethal in itself as fentanyl, although many people who die from a fentanyl overdose have crystal meth in their system. Crystal meth is an unbelievable. It's a uniquely ferocious drug in its ability to destroy people, destroy minds, destroy lives. I think cocaine is a pretty terrible drug too, but it doesn't approach the level of horror that crystal meth is causing our society and our patients. Cannabis is increasing as well with legalization. Benzodiazepines, potent benzodiazepines are available quite easily and online. So what does this mean for people working in the field? And here I'm talking, of course, from my perspective as an addiction physician, but I think I can say that everyone in the field has been, quite affected by this. There's many factors that's increasing our own sense of frustration and anxiety and anger and sadness. Patients are more likely to drop out of treatment. Treatments such as opiate agonist treatment aren't working as well as they used to. And so that's it's a sense of helplessness among care providers as they see patients who used to respond to methadone are no longer responding as well and dropping out. And of course, a realization that we don't have the resources needed to deal with the complexity and urgency of a patient's problems. So patients present not just with using fentanyl, but they're also using crystal meth, and they have serious mental illness, they have social problems, and the individual practitioner may be working alone or with one other person. They don't have the resources they need to deal with it. And on top of it, when patients drop out or leave treatment, they're at risk of dying. It could be suddenly from overdose or suicide, or slowly from endocarditis or liver failure or pneumonia, etc. And at the same time, we're seeing disruptions in service and staffing caused by COVID, and the complacency of government and healthcare institutions, hospitals, and so on. We saw the massive public health response to COVID. Nothing like that there's nothing parallel to that in terms of response to the substance use crisis. I think that I don't want to get into comparisons of COVID and substance-related harms, but we have to remember that the people dying of substance-related harms are by and large younger people, whereas people who are dying of COVID are by and large near the end of their life anyway. And so it is, I think, grating to see this lack of response on the part of government and care providers. There is reason for hope, though. I think governments are starting to respond with funding of new and existing programs. It's not enough, but it's a start. RAM clinics, addiction clinical consult services, withdrawal management services, residential programs. There is new funding coming. Too slow and maybe too late, but it's a start. And our field, I think, should be proud that we have been resilient. We've changed. We're responding to the crisis. We have new opiate agonist treatment protocols that have been adapted for COVID. So some of the old rules around urine drug screening and office visits have changed and become more flexible. We have new prescribing protocols for methadone, buprenorphine, and slow-release oral morphine. We are having greater integration and coordination. That is, medication-assisted treatment is being integrated into withdrawal management services and residential programs. We have teams of NPs and NPs working with addiction counselors and RAM clinics and consult services. And there are innovations to provide low barrier access to treatment, virtual care, patient navigators in hospitals. And we're seeing that people are starting to come together in communities of practice. This serve nurse practitioner communities and so on, and new people are entering the field. So there is reason for hope. And now I'm going to pass it on to Kate.
Good morning, everyone. I'm Kate Hardy, and I am the Network Director for the PHI program. I'd like to just spend a little bit of time this morning reviewing some of the work that PHI has undertaken in the last year to try and address some of the challenges that Mel raised. To start with, I just wanted to flag a few of the resources that PHI has produced over the last year. These span a number of different sectors that work with individuals who use substances. And of course, many of these materials can be found through our website, medify.ca. So to highlight just a few of them, please do go and explore the recently produced methadone guidelines for individuals who use fentanyl. And I know that there's a workshop on that specifically later today. We've also added a toolkit for the management of opioid use disorder in the emergency department setting. Which has a number of different protocols of interest to people that are working in the ED. Please also keep an eye out in the coming months for a toolkit specifically for nurse practitioners working in the WMS setting. And we've recently also added the latest version of one of our most popular texts, the Primary Care Clinical Handbook. So go and feel free to download your copy. I'll also mention that we've of course done a lot of work in the RAM sector, most recently undertaking the first environmental scan of Ontario's RAM clinics. I'm going to spend a little bit of time now reviewing some of the results of that scan. So in 2020, Medify was tasked by the Ministry of Health to provide oversight to the province's 74 funded RAM clinics. And this past summer, we conducted the first Ontario-wide environmental scan. The purpose of this is to maintain a provincial directory of RAM services and to better understand what services are actually being provided through these clinics. And of course, to determine what the strengths and gaps are in the services provided. To date, 72% of funded RAMs have participated. So thank you very much for everyone who's taken part so far. So just to review some of the results of this scan, of course, many clinics are very interested in how their service is similar or different from other RAMs across Ontario. And one of the key features is obviously location. So just to give everyone a bit of an idea, just under a quarter of RAMs are located in a hospital, and just under 20% of them are located in a hospital-operated community site, such as a withdrawal management center. Just over a quarter of RAMs are located in a community agency-operated site, such as a CMHA, and 11% are within a primary care clinic, 2% within an OAT clinic, and then 19% are located in a number of other types of settings. And this might include mobile RAMs as an example. Just to look at funding very briefly, of clinics that are receiving government support through OH or the LINs, 38% receive no other types of funding. Just under a third receive some degree of financial support from their host agency, such as their host hospital. 15% receive some support through a partner agency, and 15% receive support from elsewhere. Here at the Central team, we get a number of questions about how physicians are compensated in RAM clinics. So just to start off, I'll mention that 20% of RAMs do not have physician prescribers, but rather use nurse practitioner prescribers. But of those sites that do have physicians, just over a third use strictly a fee-for-service model. A quarter use a combination of fee-for-service and sessionals. 13% use salaried physicians, and 19% use fee-for-service and stipends, and then 3 and 6% use a combination of salary and sessionals or salary and stipends. So you can see it's quite a mixed bag across the board. And there was a theme of comments throughout the responses calling for some standardization of the physician payment models in RAM sites. We also asked respondents about what kinds of substances individuals could receive support for in their RAM clinics. And I'm pleased to share that 100% of respondents said that they work with individuals looking for support for their alcohol and opioid use. Just under 90% said that they provided support for benzodiazepine use, 83% for stimulant use, and 79% for cannabis use. Of course, no one on this at this meeting today will be surprised that the pandemic had some impact on patient volumes, with 42% of clinics saying that their volumes increased during the pandemic. 35% reported that volumes stayed the same, and 23% reported a decrease in patient volumes. Although I might speculate that this isn't necessarily related to a decrease in demand, but might perhaps have to do with some temporary clinic closures that we saw right at the start of the pandemic. Relatedly, we can look at the impact that the pandemic had on service delivery, such as hours of operation and providing virtual care. And I'll just mention quickly that 22% reported no changes to the delivery of services. 27% reported temporary changes, but that service delivery has gone back to normal now. And over half reported that changes are still in effect. And most commonly, this seemed to be an increase in reliance on virtual care. Those of you who are members of our listserv will not be surprised to hear that many of our clinics offer a multitude of wraparound services. There was some conversation about that recently online. So I've highlighted just the top 10 of them in this graph here. So, to give you an idea, nearly 100% of respondents reported that their clinics offered individual counseling and harm reduction. Nearly 90% reported that their clinics offered withdrawal management supports and case management. And nearly 80% of respondents reported that their clinics offer hepatitis screening and minor acute care. And these are offered either by RAM care providers themselves or by on site community partners. So, just to summarize a few again of the common themes that we saw, there was an overall reported increase in service demand since the start of the pandemic, and that many adaptations have been made throughout the pandemic to ensure continual care delivery. This could be through offering virtual care or reorganizing clinical space to ensure that individuals could continue to access care in person safely. The number one challenge that was identified by 13% of clinics was the limited hours of operation. And respondents felt that with increased funding, RAMs would be able to be open longer and therefore provide more care to their communities. I also saw comments again and again expressing the pride that people felt in the exceptional quality of care that was being provided through the RAM to their local community. So thank you so much, everyone, for sharing those thoughts. And again, to everybody who participated in this scan. We will be producing a report which with much more thorough details. So please keep your eyes out for that. I also just wanted to echo some of the thanks before we move into the rest of the day that Jennifer was sharing earlier. Of course, Jennifer, I wanted to make sure that you yourself were thanked as the conference chair. You worked an incredible amount to pull these 2 days together. So thank you for doing that and almost making it look effortless. Really appreciate all that you've put into this. Of course, also thank you to Sarah and Lori, members of our Medify team here, for your work. The conference scientific planning committee, who made sure that there was a breadth of topics covered over the next 2 days and that different backgrounds were well represented. Thank you as well to the U of T CPD team, Marta in particular, for your many hours bringing together all of the logistics. And of course, to the more than 60 speakers, panelists, poster presenters, networking session leads for sharing your expertise with everybody here over the next 2 days. Thanks also to everyone who shared your wonderful photos of the work that you're doing on the ground. We look forward to highlighting that work through these photos over the coming days. Lastly, thank you to the more than 300 learners who are joining us live today and tomorrow, hailing from all across Canada, from Vancouver to Moncton. We really appreciate you spending your time with us. Next, I am so pleased to be introducing our keynote speaker, Carol Hopkins, the Chief Executive Officer of the Thunderbird Partnership Foundation. Carol will be speaking to us on supporting First Nations' right to health. What is the critical path? Carol Hopkins is the Chief Executive Officer of the Thunderbird Partnership Foundation, a division of the National Native Addictions Partnership Foundation, and is the Lenape Nation, is of the Lenape Nation of Moraviantown, Ontario. Carol was appointed as an officer in the Order of Canada in 2018. In 2019, she was recognized with an honorary Doctor of Laws degrees from Western University. Carol has spent more than 25 years in the field of First Nations substance use and mental health. She holds both a Master of Social Work degree from the University of Toronto and a degree in Sacred Indigenous Knowledge, equivalent to a PhD in Western-based education systems. Carol has co-chaired national initiatives known for best practice in national policy review and development, resulting in the First Nations Mental Wellness Continuum framework, the Honoring Our Strengths, a renewed framework to address substance use issues among First Nations in Canada, the Indigenous Wellness Framework, and the Native Wellness Assessment. Her leadership has been engaged within health for provincial and federal governments as well. Thank you so much, Carol, for being here with us this morning.
Wewena Busho, no jam Indigenous cause gaye maingan and dodem, Lani Lanape Kwe and Dow, Lanape King and Dunjaba. Good morning. I'm joining you from the Delaware Nation at Moravian Town, which is in southwestern Ontario. This is the community that is host to the National Native Addictions Partnership Foundation and Thunderbird Partnership Foundation. This is a community that I live at as well. My father is from the Munsee Delaware First Nation, which is just outside of London, Ontario. And I'm happy to be here with you today. Disclosure, we receive a core of our budget from Indigenous Services Canada, and then we have other project-based funding. And today I'm drawing on data that was gathered through funding received from the Public Health Agency of Canada through our First Nations Opioid and Methamphetamine Survey. And I have no other external funding to report. So we do have the relationship with Public Health Agency of Canada, Indigenous Services, and as I said, I am the CEO of Thunderbird Partnership Foundation. So today I want to talk to you about Indigenous wellness and the role of trauma in drug use amongst First Nations people, and talk about what is a trauma-informed approach to harm reduction and treatment. And then I want to finish off by talking to you a little bit about a model of care that has demonstrated significance in First Nations communities, and primarily in rural and remote areas of Canada. We draw our mandate from the First Nations Mental Wellness Continuum framework. And so today, what I'm going to share with you, I've situated within the 5 themes of the Mental Wellness Continuum framework: culture as a foundation, community development, ownership and capacity building, quality care systems and competent service delivery, collaboration with partners, and enhanced flexible funding. All 5 of these themes have critical importance to guiding that critical path for providing services to First Nations people, families, and communities. I encourage you to look further into the framework by visiting our website, thunderbirdpf.org. So the first theme is culture as the foundation. And what we mean by that is that framework was developed in conversation with First Nations people and the partners they chose to include across Canada. And resounding in that conversation was that we have to use our own knowledge as Indigenous people, Indigenous knowledge, sacred knowledge, and our cultural practices if we're going to make a significant difference in our communities. So we've lived through colonization, still are in the midst of decolonizing. And in that process of colonization and racism, oppression, our knowledge systems and our practices have been set aside, discounted, and outlawed. And we are, as First Nations people, recognizing that they've never disappeared, but they've been displaced. And so many of our communities have become disconnected. And if we're going to make any significant difference, then we have to focus on the strengths of First Nations people rather than having a conversation that is solely based on our deficits. Because then if we are focused only on deficits, it becomes an overwhelming story, difficult to engage partners to support wellness of First Nations people. And we never know when we get to wellness because we're only focused on deficits. So culture is the foundation of the strengths-based approach. Culture-based practices and practitioners, elders for sure are a source of knowledge for that sacred Indigenous knowledge because they have understanding of language, the meaning of language. And so our languages, the First Nations people, our original languages convey whole concepts. It's primarily a verb-based language. And so when we talk about pain, for example, there's many different ways to describe pain. And it's in relation. So our language is relational. It's in relation to environment, in relation to people, and also in relation to the whole person, mind, body, spirit, and emotion. And so when we use our language, we talk about, especially in the context of addressing substance use, our language is medicine, critically important. Also is a connection to land. And so understanding land as our relative, our mother, the earth, is a common way of describing our relationship with the land. Our first mother, all life comes from our mother, the earth. And then we know that from the earth that the Great Spirit gave and ensured what was in place was our medicines. And so there are different kinds of medicines that are important for helping people in their wellness and recovery. So some years ago, as First Nations people started to rely more on land-based services, and particularly in the territories where they didn't have residential treatment services, they relied on their cultural practices for going out on the land. And for many communities, especially in the Yukon, that were operating under self-government, they didn't need permission for funding. They had control over their funding and could determine how they were going to use those based on the community needs. And so they had spent a lot of time investing in land-based services. But as they began to tell that story, more and more communities across the country started to articulate their use of land and their connection to land. In the early 90s, we heard a lot about the Innu Nation in Labrador, who was struggling with a way to address inhalant abuse and the effects of the inhalant abuse, gas sniffing. And one of their strategies was go back to the land. Land is important because it's a natural way of living, being on the land, in connection with land, relationship with land. And so it's important because it allows that self-governance. It's a way to facilitate decolonization in that being on the land with elders, cultural practitioners, it regains and focuses on a sense of identity, which is critical to wellness. We know that for people, First Nations people that do not have a connection to their identity and do not believe that their culture matters, they're 3 times more likely to be using opioids in a harmful way. So land is a teacher. It's also a healer. And it's a way to, there are programs across Canada who have invested in land-based services. We developed a land-based service delivery model because as communities began to talk about the land-based services and put that into funding proposals, government had little understanding about land-based services to be able to understand what that might mean in terms of policy and funding. So the land-based service delivery model was created through conversation and examples across the country of programs, specifically substance use programs, who are supplementing opioid agonist treatment, for example, with land-based services. It's critically important aspect of healing and wellness. So in my bio, it was mentioned the Native Wellness Assessment, and this data is filtered by looking specifically at cultural practices, and we call them cultural interventions, trying to translate culture into language that is more accessible and more easy to have conversations to facilitate understanding. So we've called them cultural interventions, and these different cultural practices. And so out of a conversation that we had with CIHR funding, we had conversation across the country with Indigenous knowledge keepers and communities about their community-based practices across different languages, across different cultures, across different land. And we asked, what is a whole and healthy person from that sacred Indigenous knowledge, your teachings? And so across the country, everybody said, of course, mind, body, spirit, and emotions. And then we asked, what are the cultural practices that facilitate a whole and healthy person, balance in mind, body, spirit, and emotion? And then when we use those cultural practices or cultural interventions or live that cultural way of life, what should we expect the outcomes to be? What results does it achieve? And through that conversation, there were about 40 different cultural practices that were similar across the country. For example, language, prayer, being on the land, listening to teachings, spending time with elders, picking medicines. And then there were certain ceremonial practices such as sweat lodge, for example. And so we've been collecting this data through primarily treatment centers, the National Native Alcohol and Drug Abuse Program and the National Youth Solvent Abuse Program since 2017. And we filtered that data looking at all of the practices specific to land so that we could start telling the story about the difference that being on the land makes. And so what this shows in the bars is the entry and exit of services that offer culture and land-based activities. And we see significantly that there is consistently an increase in wellness in belonging and purpose. Belonging is about having a connection to family, community, having relationship not only with people, but land and environment, and having an attitude towards living life. Knowing that no matter what we face in life, the Creator ensured the possibility for an answer, and that requires belief. And then purpose balances belonging, because purpose says that I know I have reason for being, and that there are unique ways that we live as people, as Indigenous people, and unique ways that we live together and do things, and that as a whole being, I'm aware of my spirit, my emotions, the way I think and the way I understand the world, and that all of that gives me purpose in life. That the results of the treatment services using land to address substance use. In the bottom of the screen, you see those boxes that say groups 1, 2, and 3. And so those are different categories of cultural practices, some that are offered daily or several times a day to weekly or monthly, and then annually or seasonally, such as fasting, for example, is a critically important way for connecting and establishing that relationship and being nurtured by our Mother, the Earth, and our relatives in creation. And so this is data that demonstrates the significance and importance of land for folks who are addressing substance use issues. The second theme is community development, ownership, and capacity building. I really loved the presentation that Kate made when she was talking about the RAM clinics and the services they provide, because there was in that the importance of connecting to community and offering wraparound services. For First Nations people, those in rural and remote communities, those are the same services that are needed. In fact, in rural and remote communities, they in First Nations communities, we need those exact same services that are often only found in urban environments. And I want to say Chimigwech as well to all of the clinicians, nurse practitioners, and addictions medicine physicians who invest in First Nations communities through community development and building their capacity. And so through that support, there has been conversation with chief and council to advise about the type of services that would supplement and enhance services to First Nations people who use drugs and retain them in treatment. So through workforce development and training, what kind of training is necessary to support people who use drugs? And so elders and cultural practitioners have said to us, we need to know what type of drug and how does that drug affect people so that we can use our knowledge, our ceremonial practices, our knowledge of medicines to support individuals, not in conflict, not to direct a physician or a clinician, but to work in partnership from our worldview and what we know makes a difference. So those conversations with community chief and councils, elders, cultural practitioners is an investment in developing community policy and programming. And it's support to First Nations government. Many physicians, clinicians are recognized as experts, and you advise provincial, federal governments all the time. It's advising First Nations governments. Your voice matters. It's not the only voice, it's in collaboration with. And so that works best when there's respect for community strengths. And so oftentimes when you're working in a First Nations community, it's easy to see all of the challenges, but it's critically important that you understand the strengths that the community has. From the First Nations opioid and methamphetamine survey, we know that 30% of the people that have answered our survey, and at the time of this slide, this data, we were almost at 1,000. We are now at about 2,500 survey respondents. But the numbers seem to be consistent. About 30% of the population answering this survey have indicated that they are using opioids in a harmful way, outside of a prescription, using more than the prescription calls for, obtaining opioids through family, community, or other sources. And why are they using? They're using it because they're having a rough time and they don't know how to get through that rough time. And what is that rough time about? Well, we know the history is 97% of the people answering the survey have had a history of family involvement or personal involvement in residential school experience. And then from that, they have upsetting memories. They've had experience with loss to suicide. Either their family or friends have attempted, or they have completed suicide, or they've experienced crisis in their community. So the displacement, for environmental crisis, they get moved out of their community, or community is in crisis because there are high rates of substance use. And from that, suicides and other types of violence and trauma. And so this gets compounded, and individuals use opioids to self-medicate and relieve themselves from that pain and that trauma. Now, through the displacement and colonization experiences that we continue to live in, we have not had access to our culture, our cultural practitioners, our elders, and land. It isn't a formal part of programs and services. It has not been core to the way we deliver health and social programs in our community. That's beginning to change. But outside of that, we've also not had services in First Nations communities by provincial funding through addressing substance use and mental health, other mental health challenges. So dealing with the trauma and the grief and loss and suicide or life promotion. And so this is the story that we have. So as I said earlier, for those folks that have experienced grief and loss and have that history of trauma, they're 3 times more likely to be using opioids in a harmful way. Whereas people who have that connection and relationship goes back to belonging again, and who have a sense of belief in their culture or identity and know that that matters in their life, they're three times more likely not to use opioids in a harmful way. It gives us direction for how we need to invest in communities. When we don't invest in practices that have meaning to First Nations people, we address part of the problem, but not all of the problem. And so we know that in First Nations communities where there have been support for access to methadone or Suboxone, buprenorphine, naloxone, that medication is not a silver bullet. It doesn't solve the community concerns and challenges. It supports people who are using drugs, but it also has an impact. We have to understand the impact for family and community. So when I was talking about that history and the presence of trauma, that's not only for an individual, it's for many people in First Nations communities, if not the whole of the population. And so our solutions, our support have to attend to the impact and the outcomes for family and community as well. And when we invest in those conversations with community government, we build relationships with community workforce, and we understand the context of funding for First Nations communities. The federal government is not responsible for funding nurses, nurse practitioners, and physicians to deliver primary care. The nurses in First Nations communities have significant limitations in terms of their scope of practice. And so it's that are funded by the federal government through the First Nations and Inuit Health Branch. And it is the provincial and territorial governments that are responsible for mental health. And we need to support advocating with provincial, federal, and territorial governments to invest in First Nations communities. Other dynamics that we know in First Nations communities is there's a lack of food security. And we've heard from First Nations people, 48% said that they use methamphetamines to also address that food insecurity. Because when they're using meth, they don't have any appetite. They don't have to worry about where their food is coming from. During COVID-19, we saw an increase in alcohol, in methamphetamine, and in opioid use. A glimmer of hope, we see that First Nations women who are using opioids, 90% of them are gaining access to treatment. But there are significant risks for folks, as you know, who use methamphetamines and opioids at the same time. And so we're starting to see, communities are becoming much more aware of the significant harms for folks who are using methamphetamines and opioids by injection. And polysubstance use, opioids and alcohol together, and emergency room visits for opioid methamphetamine use. And then about 24% are attempting suicide because of their drug use and lack of access to services. So this is data from the Addictions Management Information System that treatment centers across Canada use. And on the left side of the screen is pre-pandemic. On the right side is during the pandemic. And I call your attention to the blue sections of the bars, and we can see that in the blue bars that are highlighted in red indicates an increase. So there was a report of less alcohol use, but for those who were using alcohol, opioids, stimulants, sedatives, they increased the frequency of their use to 20 or more times a month. So the severity of alcohol and substance use grew during the pandemic. So during the pandemic, treatment centers modified their program to fit a virtual environment. And so much of what they offered were psychoeducational sessions. And they registered their clients. And so there was case management. And they administered the drug use screening inventory and the native wellness assessment. So throughout the pandemic, then we see that there continued to be an increase in the balance of wellness over time through virtual services. It's an indication about the importance of culture. And so elders who were offering teachings, talking about their well-being, the meaning of their identity, continued to resonate and draw people in who were struggling with substance use but could not access residential services. Next, I want to talk about quality care systems and competent service delivery. And this is the relationship that you have as physicians with First Nations elders, cultural practitioners, and what is required to invest in that relationship. So we've seen communities that have, again, physician present in the community, the clinics that offer access to buprenorphine naloxone or methadone, but have no other relationship with the community, with the cultural practitioners, the elders, the community government, or the health and social services. And over time, frustration and resentment grows in the community because individuals who are accessing opioid agonist treatment are not getting any other services, and they continue to use other substances. And so the growing concern is that, well, that doesn't work anyways. All we're doing is enabling the addiction. And we all know that's not true. So it's the lack of those wraparound services, but significantly, it's the disconnect between worldviews. And so that relationship is required to ensure quality care and competent services. So Indigenous harm reduction means investing in understanding, and not that you are expected to know Indigenous knowledge, languages, or that you would facilitate culturally based practices out on the land or ceremonies. But it's important to know the value of it. And it's important to know that as a clinician, you can be trusted not to judge, not to discount, and not to dismiss. In fact, you're aware of the services in the community, or that you may have heard of operating in other communities, and you can advise on the significance and the importance and support that. That leads to ensuring better policies and programs. It's a process that you invest in that facilitates decolonization and valuing. So it's critically important to approach community-based services in that way. And that, in effect, becomes trauma-informed services and culturally safe services. Indigenous Services Canada, through core funding to First Nations communities, on our side at Thunderbird Partnership Foundation, we continue to advocate and advise about the importance of outreach services, increasing the community-based workforce to invest in peer-led services that can supplement rapid access to addictions medicine. And and educate communities about the importance of harm reduction. And again, on that side, we are also supporting First Nations governments, tribal councils, in exploring those partnerships with provincial government, with clinicians, and how to ensure that land-based and culture-based services are formalized in their policies and their programs, so that that workforce, elders and cultural practitioners, can also be adequately compensated and retained to support the services. We've heard also from First Nations communities the significant issue of wage parity. And so First Nations communities have said that it's not hard to attract a qualified workforce, but it is difficult to retain them because they don't have the funding capacity to pay adequate wages. And so First Nations communities become a training ground for other services, often provincial services. And, we have to think about culture beyond what we see in behavior, and understand that there's deep meaning that transcends generations, and it can't be found. I mean, we can read about culture, but that's that sacred knowledge that underpins the meaning of our cultural practices is found in sacred societies. And just like when we go to university, there are requirements that we have to move through, criteria, standards that we move through to ensure that when you're finished, that you have the valid credentials. That's parallel to what happens in sacred societies. And so we have the middle ground where people have had experience in participating in social and ceremonial practices and assume that they have the knowledge to then be the practitioner. And that's not the case. So I use this image of a powwow to illustrate that, many people come to a powwow from all different nations to observe and to participate and to understand what Indigenous culture is about. But we're seeing behavior without understanding meaning. And we have to invest and be open to understanding meaning. And so all of the regalia in this picture, the dress, the feathers that are used, the way that they enter the arena in the circle, the progression of the different types of dances, the way their feet touch the earth and their movements all have significant meaning. And that is not easily, you can't observe that, but you can observe the behavior and wonder about the meaning. So First Nations communities, again, through our survey, have said we need, and people who use drugs have said, we need ceremony. We need to use our culture in addition to access to opioid agonist therapy. We need to include our families. And so from a Western-based perspective, we address substance use from the individual perspective. What people have said across the country through the First Nations Mental Wellness Continuum framework is that if we are going to make a difference, it's not just the individual, it's the family and community that we also have to invest in. So some key principles for supporting substance use treatment means ensuring equitable services. We need allies to champion the voices of First Nations communities. It's not just the provision of opioid agonist therapy, it's investing in the community. It's building those trusting relationships and participating in discussions across the different sectors within the community and ensuring there's barrier-free service. I know it can happen because there are physicians that do that now. And that standards of care we've heard from First Nations for service providers is recognizing that First Nations have choice. And oftentimes we hear, well, this is a predominantly Christian community and they don't want anything to do with culture. I've heard non-Indigenous service providers say, well, we heard that blah, blah, blah. Remember that those individual stories are individual stories, and that we should always question them, because the importance of access to culture is facilitated through asking those questions. And so I was a director of a youth treatment center for many years, and those were the common things that we heard, because we offered a culturally based program. We heard that Christian-based communities, or where Christianity still had strong influence and dominated communities, First Nations people themselves did not want culture-based practices. And yet they continued to send their youth to the treatment center. And we required parents to come and live in the treatment center for at least a week. Over time, what we saw was that these families did not have access to culture, so they did not understand what they were saying no to. But once they got to the center and they experienced the culture and ceremonial practices that we offered, they wanted to come back. The parents wanted to come back. And they came back for 2 and 3 weeks with another sibling, because they understood what culture was once it was offered. So we have to ensure and work together to advocate for that capacity. Collaboration with partners, and I'm almost finished. This is the model that we've been talking about more and more. And so I was asked to co-chair a Northern Public Health Working Group on mental wellness. And through that conversation, we heard from many communities that a hub and spoke model is one model that will ensure services to rural and remote communities. And it's the community that is the hub. It's not the hub in a health authority outside the community. The community has to be the hub. And so when we understand the community as the hub, we're working with the community government, we're working with community workforce, with family, with cultural practitioners, with elders, and access to their ceremonial cultural practices and land. And then we are supplementing that care with rapid access to addictions medicine, access to 24-hour crisis and chat functions. And we've heard that more and more communities are reaching out for culturally based services rather than clinical, and that we facilitate and support communities with various harm reduction methods. We are attending to food security, housing, and those family-based supports. So when mom is having a crisis based on the polysubstance use of maybe one of your clients who is an opioid agonist treatment, and she needs to ask questions about that. She needs to understand what's happening for her youth or for her family member, and she wants to be able to talk to a clinician. There are clinicians that have taken those calls, although the mom is not the patient. And so working in that model where we are not just attending to an individual, but the family and the community. Now, the 24-hour crisis line is also critically important, but having that relationship with community means investing in community. And I wonder about the payment model, the compensation model that facilitates those kinds of services. But we know that there are limitations. And the limitations are what we've heard from various clinicians is, how do you monitor your patients then when there's that geographical distance? Lots of physicians and clinicians have traveled and spent time in these communities. We also know that there's limited digital capacity in First Nations communities that significantly impacts their access to virtual care. There's limited access to outreach resources. Like I said, First Nations who have invested in harm reduction and opioid agonist therapy, ensuring they have capacity for outreach, don't have the resources to sustain them. There's limited access to pharmacy. I'm currently having conversations about how do we access naloxone for First Nations communities. Bulk access to naloxone is a challenge across the country. Getting clinicians interested in and involved in these types of measures requires our collective support. And I'm sure you've heard the national conversation on racism. Prescribing outside of regulations, outside of best practice guidelines, or creating barriers, holding folks hostage to methadose when they could be on buprenorphine, naloxone. Those are practice challenges that we face, and that in some regions they've identified those practices as racism. And together we have to work to ensure that we are addressing those very issues. And then there's the First Nations addictions workforce. They have a high rate of certification in addition to their post-secondary education, but we know that in Ontario we did a case study, and this is now about 4 years old, and there has not been significant change. That workforce is paid 47% less than the addictions workforce in Canada. That's an act of racism as far as I'm concerned. And so it's understanding the funding challenges, the access challenges, the infrastructure challenges, and the desire to be an ally to First Nations and work with us to address these challenges. So I'm going to say Chimigwech again, and thank you very much for the opportunity to spend some time with you today. And again, I encourage you to visit our website, thunderbirdpf.org, to look at some of our resources. Thank you.
Thank you. Thank you again for being here this morning and for sharing that presentation with us. We did have a number of questions come in through the chat. So I see more questions are coming in, but let me start off with the first that we received. One of them, Carol, was about the surveys that you mentioned. Are you able to maybe at a high level just speak to who the respondents were and how they were sort of sourced? How did you reach out to individuals and who took part in these surveys?
Yeah, the surveys were administered and implemented in First Nations communities. And so we often get First Nations communities, regional governments or tribal governments that reach out to us around their concerns over the lack of access to substance use services. So for opioids, methamphetamines, and sedatives. And so we started off under the Canadian Research Initiative in Substance Misuse to develop community guidelines for addressing opioids. So it was a conversation that we were engaged with in community to discuss how are they addressing opioids and the impact of them in their communities. That conversation led to, as we were in the midst of it, a concern about methamphetamines. And so we added that to the survey. And then we added a section related to the pandemic. And so that survey was developed with a number of clinicians who work in First Nations communities and understand the impact of trauma, of colonization, of racism and oppression. And together, with a national committee then, we developed the questions, and we had some support from some colleagues at the Center for Addictions and Mental Health. to draft the survey. We tested it in various communities, revised it many times, and now it's being implemented in First Nations communities across the country in some of the territories as well. And so it's a community-based survey. It collects it's individuals that are answering the survey, and it's a whole of community perspective. So it's not just people who use drugs. It's everyone in the community, because we want to understand the role of trauma. We want to understand community perceptions and support for harm reduction. We want to understand access and availability of services, access and availability of cultural services, and what types of substances are being used and where they access them from. So there's an adult version and a youth version. And we have a number of educational materials that supplement the survey. And so a community who wants to participate in the survey can access those materials and deliver them themselves. We have conversation with them about what are the key issues that they're facing, so we can develop some communication around that. And then we have staff who actually go to the communities where possible to support the implementation of the survey. And then we produce a community-based report, and then we report on the aggregate data.
Thank you. And I'm seeing lots of thank yous coming into the chat as well as you're providing these explanations. So let me move on to the next question we received. What would you say to those individuals working specifically in RAM clinics, but what they can do to support Indigenous clients?
The first thing that comes to my mind is, what's the context? Are they in community or are they in a city? I focused a lot today on rural and remote, because rural and remote communities don't have access to RAM clinics, and predominantly. And so when there are clinics, it's building relationships. As again, I cannot stress that. It may sound simplistic, but it's critically important to understand from the clinician side of things, what are the communities that folks are presenting from. So when you have Indigenous people in your services, whether it's rural, remote, or urban, where are they coming from? And how are they connected to their communities? And why are they, what relationship do they have with their community? We know that 3 factors are very critical to mental health, and that's identity. And so through colonization, we've had many people disconnected from their identity through child welfare, through criminalization, and other things, residential schools. So identity, it matters. Who are they? Where are they from? Who is their family? What is their community? How often do they visit their community or the territory that they come from? That's critically important. And when you think about the relationship between mother and child, that's a lifelong relationship. Going back to the land that you come from is the same as having that relationship with your biological mother, or having a relationship with a significant caregiver that you can count on. In that same way, it's important for Indigenous people to know where they come from. So the third one is their language. So land, lineage, and language are critically important for supporting First Nations people. And so whether you're seeing them, whatever environment, rural, remote, and urban, it's important to have those conversations. It might be that First Nations people don't understand the importance of those things themselves. But facilitating a conversation with genuine interest in knowing that those are those are important factors that are determinants of their health and their wellness, then it's important to initiate those conversations to know where there might be resources in whatever environment you're working in, and reach out to understand how do you facilitate referral.
I see one that's just come in asking, how does the approach for treatment or treatment for youth differ from adults?
There are significant differences in that it's developmental needs. So for young people, that stage of life, we know that their prefrontal cortex is not fully developed. They're not, they don't have the capacity that adults do for critical decision making, for consequential thinking. And it's important to focus on development of skills for critical thinking, for delayed gratification. And so when I'm going to tell you one of our cultural practices that is important for developing those skills around delayed gratification is fasting. And so throughout the lifespan, we know that there are developmental stages. And from a cultural perspective and our Indigenous knowledge, we know that along those developmental stages of life, there is importance to pay attention to the spirit. And so, birth and infancy, early childhood, there are needs. At the adolescent stage, there are needs. And so, from a cultural lens, we call that adolescent stage the fast life, because at that stage of life, they're learning about their sense of self and their relationship to others. And so everything is about, their peer group and their appearance and how they identify themselves. And everything is what I want, and I want it now. The fast life, they can't wait. And that's why it's important to develop the skills around delayed gratification, slow life down, understand what it takes to invest something now for a payoff that's going to come later. And so another side to understanding fast life is it's important to fast. Fasting is about supporting that connection to one's own spirit and the spirit of creation. And so it's actually going out and sitting on the land with lots of ceremonial protocol around that. And there are different ways to fast, going without food and water, without people, without the warmth of the fire, for a period of time. And those four medicines, food, water, fire, and people, family, those are medicines that we require for life. But when we choose to set them aside for a period of time with ceremonial protocol, then we are investing in our spirit. So we let go of the physical side of life, and the spiritual side of life has an opening that gets stronger. And so we're nurturing that spirit side of life. That fasting is about the future. It's looking for life. It's preparing for life, and understanding where life comes from, our relationship with the land and environment, and knowing that we can survive. We learn to survive the loneliness, the hunger. We learn that it's temporary for a longer term payoff. That's delayed gratification. And there are different types of fasting, as I said. When it's the first menstruation time, that rite of passage, there are significant things that happen there that are important for developing delayed gratification, but developing a sense of self in relation to others, and also learning about what your spiritual strengths are that are necessary for life. That is supposed to happen at the adolescent stage of life. But again, because our culture has been displaced, not every adolescent has had the opportunity to experience that. For adults that sometimes have grown up in a traumatic environment without those 4 medicines, without a connection to family, without knowing about water and fire, for example, and the spiritual meaning of that for their identity and for the wellness of their life. And that sounds very simplistic, but I'm talking about the spiritual understanding of those elements of creation. Then maybe they haven't developed the delayed gratification, and we certainly see that in addictions and substance use. Um, but it's helping to understand that for youth, it's so in the residential treatment program that we offered the opportunity for fasting, and it was that ceremony that actually drew in the parents for the youth, and then parents would decide that they wanted to go fasting as well. So they came for the 1 week requirement, but chose to come back again because they wanted to go fasting. And for us, that was true family therapy and offered the best opportunity for long-term recovery of from the substance use, but also to facilitate stronger family relationships. For adults, we're dealing with helping them to stabilize their life, where they have responsibility for food security, income security, housing, often addressing issues with justice, child welfare. Those elements are critically important in addressing substance use. We know that women and men actually, who have had their children taken away, and then they have all of these requirements they have to meet before they can get them back, is overwhelming. And oftentimes those conditions and those criteria are placed on individuals with no means to fulfill them. And they choose to medicate the anguish and the trauma of no way out with substance use. And so it's those factors that sometimes are critically important in the difference between treating adults and youth.
Carol, thank you so much for sharing your time and your knowledge with us today. I'm so sorry that we're out of time because I know these questions and the comments are continuing to come in. We will have to say our goodbye here and invite everybody to return to the lobby to head out to your first sessions and workshops of the day. You'll have all seen that there's a banner at the top of your screen inviting you to take part in a feedback survey. There will be an opportunity to do that later as well. So once again, Carol, thank you. And everyone else, please enjoy the rest of your day. Thank you again for being here. We'll look forward to staying connected over today and tomorrow.
Jimmy, good for the invitation to spend some time with you.
Thank you. Take care.
Bye now.